Thank you everybody for joining me today to talk about the quality payment program and the changes that are in store for us for 2018. My name is Bruce Maki. I am from MCDA or Altarum, depending on how you know us. A lot of people know me through MCDA. MCDA is really just a department within Altarum. Altarum's the parent company. We are Michigan's Regional Extension Center. So at the same time that the Meaningful Use Program came about back in 2011, they started incentivizing providers to use their EHRs in a certain way. They also funded this network, a national network of regional extension centers to kind of be the boots on the ground, to be out there kind of helping you guys make sense of these extremely confusing programs and helping you to be successful in them. So that's who we are. We are Michigan's Regional Extension Center. And if anyone can be said to be a subject matter expert in this program, I'm probably it. Depending on the time of day, I may agree or disagree on that. So we'll go through all of the changes in the program this year. Feel free to interrupt me with questions. We'll also hopefully have some time at the end for additional questions if I've completely confused you in all of this stuff. So we'll go ahead and get started. I'm not going to give too much of an overview on the program. Hopefully you guys at least have somewhat of a basis of what this quality payment program is. But from a very high level anyway, we'll go through a couple of quick slides to give you kind of the basis for the program. The Quality Payment Program, which is embedded within MACRA, the Medicare Access and CHIP Reauthorization Act of 2015, it required CMS to give us something called the Quality Payment Program. There are two paths to participate in the QPP. You're either in the MIPS track, the Merit-Based Incentive Payment System, or you're in the Advanced APM track. And so if you're in a certain type of ACO, you might find yourself in the Advanced APM track. That would be a track, Medicare Shared Savings track 2 or 3 would be the Advanced APM. A track 1 is not, which makes up about 90% of the ACOs out there. But if you are in the Advanced APM track, then you're not worried about all this MIPS stuff that's very confusing. It's kind of the less intensive way to participate in the program. But we generally have a mix. There's also really a middle ground here. If you're in one of those MIPS APMs, as they're called, which is the MSSP Track 1 ACOs, you're kind of in the middle ground here, where you are technically in some type of advanced payment model, but there's not enough risk built into it, so it doesn't get you over that hump into the Advanced APM track. So you find yourself in that ACO, but still have to participate in the MIPS track. So all of these changes will apply to you then. So MIPS, again, is the Merit-Based Incentive Payment System. It's a combination of some legacy programs that we have been using for a number of years now. It takes the Medicare EHR Incentive Program, or the Medicare Meaningful Use Program. It takes the PQRS program, the Physician Quality Reporting System, that's been around for about 15 years or so. It takes the Value-Based Payment Modifier, puts all those 3 programs into a blender and gives us MIPS. So within MIPS, we have 4 performance categories that you have to report in order to fully participate. We have the quality performance category, which is really just a revamp of the PQRS program. We have the cost category, which is essentially just a reworking of the value modifier program. Something called advancing care information, which is really just meaningful use. It's just meaningful use with some different scoring and a new name. And then we have this new 4th category called improvement activities. And while the category itself is new, what's the activities that's contained within it most definitely are not. They built that category off of the patient-centered medical home model. So if you're familiar with the PCMH model, these activities will be very familiar to you as well. So one thing that didn't change is who can participate in year 2 of this program. So there's only 5 provider types that can participate. This is the same that we saw in 2017. It carries forward into 2018. We are going to see this list expand significantly as of 2019. We don't know exactly to who it's going to expand to. CMS will finalize that later this year for us. But for this year, it's exactly the same as last year. We have physicians, which I will note, that's really anyone who can call themselves a doctor would fall into that. So it's MDs, DOs. It even picks up chiropractors, optometrists, podiatrists. So there's a lot that goes into physicians. Then we have the PAs and the NPs, clinical nurse specialists, and certified registered nurse anesthetists. Those are the only providers that can participate still this year. Again, next year, the program is going to expand, and it's going to pull in a whole lot of other ancillary providers right down to clinical social workers, and we don't know what it's going to be yet. We've seen some kind of preliminary lists, but it's really, they're going to pull in everyone under the sun into the program next year. This is a significant change that is going to cut about 300,000 additional providers out of the program in 2018. So there's a 250,000 providers that were forced to participate in 2017. They've raised the low volume threshold that is going to cause hundreds of thousands of providers to take the year off. So in 2017, that low volume threshold was 30,000 in Medicare Part B allowable charges and 100 patients. So to opt into the program, to be a MIPS provider, both of those conditions had to be true. You had to have more than $30,000 in Medicare Part B allowable charges over a 12-month measurement period, and you had to provide care for more than 100 Medicare Part B patients. They have now upped that for this year significantly. This year we are looking at 90,000 and 200 patients. So if you do not have more than 90,000 in Medicare Part B allowable and provide care to more than 200 Medicare Part B patients, you are not a MIPS provider. The program does not apply to you anymore. Any questions on that? There's a lot of times where it makes sense to opt into the program anyway, to voluntarily report for the program. It sometimes makes sense to form a group. So you have a group of 10 clinicians that are under a tax ID. None of them are over that low volume threshold on their own. None of those 5 are at 90,000 and 200. But collectively, you can get over that hump with group reporting. So that low volume threshold stays the same if you group report. So you can consolidate under your tax ID. Those 5 clinicians then are essentially one program entity, and all of the visits get grouped together and all the charges get grouped together. So it's a way to get into the program that way. You could also, but if you don't have to report and you do anyway, CMS wants your data. They're begging for everybody's data anyway. Just know that if you voluntarily report in the program, your data is also going to be publicly available. So if you didn't already know that, everyone who's participating in the program, your MIPS score and all your quality data is going to be available on the Physician Compare website. If you voluntarily report, your data is still going to be on there. So it might, if the data doesn't look good and you didn't have to give it to CMS, you might not want to because it could end up hurting you because it will be publicly available. We see some changes in the performance periods for the categories.
So if there are physicians, nurse practitioners, PAs in the same clinic, are those NPs and PAs collectively joined with the numbers of the physician?
You can. That's your option. So you can either individually report and just stay as individual reporters, and each one just sends their own numerator and denominator, and their score gets adjusted, or their reimbursements get adjusted based on that score. Or you could collectively group together. You can do what's group reporting, and you send one set of data where you're adding all those numerators and denominators together. And then everybody gets the same score, and your adjustments are the same across the entire tax ID then. Okay. So in these performance periods, we saw in 2017, quality was a minimum of 90 days, so you could report anywhere from 90 to 365 days on your quality measures. The cost category was not used at all. They are still going to provide 12 months of data to you, just so you know how you might have scored if they had used that category last year. Improvement activities was a minimum of 90 days, and advancing care was a minimum of 90. Slight change for this next year. For 2018, quality is a full 12 months of data, so it's not a minimum 90 anymore. All your quality is going to be reported for the entire calendar year of 2018. Cost, we weren't going to use cost at all. We are using cost this year after all. This comes up on a future slide, but we're going to use cost at 10% this year, and that is also a full calendar year of data. There's no additional reporting that goes behind that. They get all that off administrative claims, but you will be assessed on cost for an entire 12 months this year. And then improvement activities in advancing care are still that minimum 90 days. And again, it can be anywhere from 90 to 365 days. That's your choice. It's not necessarily to your benefit to report for longer, but it might be, just depending on what those reports look like. But you get to choose that. So no change to the submission method. So there's a bunch of different ways to get your data to CMS. None of that changed from, unfortunately, none of that changed from 2017 to 2018. We were really hoping and bucking for one significant change that for some reason I have yet to get an answer from CMS on why they delayed this to year 3. But it's this note right here for the use of multiple submission mechanisms. We really needed them to finalize this for this year for you guys, and I'll explain why. It matters with quality data. You need to be, many providers are working in multiple EHRs. You know, you don't just have your one EHR, you're also moonlighting somewhere else, you're working in the hospital, so you're charting in 2 different EHRs. Right now, in 2017 and again now in 2018, unfortunately, you can only send one set of data to CMS. So, and there's no manual attestation of quality data. You can't just print out 2 reports and then add those numerators and denominators together and then send that data to CMS. The only way you can consolidate quality data from 2 EHRs is by employing a registry, by paying for a registry, by finding a registry that can interface with both of those EHRs, extract the data, they can consolidate it and send it on to CMS for you. But that's the only way to do it. CMS will only accept one data set within each performance category. So that makes it very difficult. It's a stopgap for some. It's actually preventing providers from really scoring well or scoring completely or scoring legally. People are having to lie and cheat and steal to try and get their quality score in. We really needed CMS to allow these multiple submissions within a category, and I don't know why they didn't, but they've promised us that they're going to defer it to year 3, so hopefully that gets finalized. Because if you're working in 2 EHRs, it can be really expensive. Those registries will charge you a fortune to interface with both EHRs and consolidate it for you.
If I have an EHR from hospital 1 and I have an EHR from hospital 2, let's just say for the purpose of discussion, 2,500, 2,500. I just report EHR 1, 2,500. Am I under-reporting now?
Yeah, you're in danger of getting audited and getting penalized for that. Because you have to meet data completeness. That's the, I'm coming up on another slide here. So the issue with quality measures is this notion of data completeness. Yeah, good segue right to the next slide. So data completeness dictates that a certain number of patients that could have that quality measure applied to them must have it applied to them. So the example I'll use is NQF 59, which is the standard diabetes A1C outcome measure that a lot of people are using. So what data completeness with that measure in particular, that measure is looking at your diabetic patients. Data completeness says that you have to apply that measure against that percentage of those patients. So if you have 500 diabetics in your panel, you needed to apply NQF 59 this past year against 250 of them. Next year, it has to be 60%. The reason they have this built in is it's easy to game the system, especially when you step away from EHR reporting, if you're like doing claims-based reporting, where you're just entering a G code on a claim to indicate that you want this provider or this patient scored against that quality measure. For your diabetics, you could just choose not to put that G code on all of your out-of-control diabetics and just put the G code on all your diabetics that have their A1Cs under control. It would tell CMS, it would give you this incredible quality score on that measure, but it's because you didn't give CMS the data on your out-of-control folks. So they built this data completeness thing in to kind of force you to apply the quality measures against all of your patients. So in your example then, sir, is if you're only reporting out of one of those EHRs, you haven't reported on that other half of your patients on that quality measure. So by default, you're going to fail data completeness on that quality measure, and you have misreported, and then who knows what's going to happen. Certainly, you'll get, I don't know if you get fined or whatever, but if you get audited, you will fail. Because CMS also knows who, they can see who your Medicare patients are that have that diagnosis of diabetes. Right. And so the numbers that you tell them better jive.
And the location.
the location, yeah. CMS has all that information. So they know where your patients are. And they know some of the numbers that they should be seeing. So if you tell them different numbers, it's going to raise a red flag and you're going to get audited.
So with respect to MOQC, because they provide some of that, you have to make sure they hit both EHRs.
That's correct. Mm-hmm.
For us, it's a little easier because we have MOQC.
Yes, yes, yeah. With the registry that you guys use, I think they're hopefully they have that all under control and are able to work with multiple EHRs and consolidate that data for you. I also mentioned the weights changed a little bit. This category was worth 60%. In 2017, it's worth 50%. That other 10% has moved over to the cost category. So you'll see this kind of laughable burden reduction aim come up over and over again. This is CMS's way of kind of trying to appease all the complaints. It's almost laughable to call it a burden reduction, because if this program does nothing to reduce the burden on you guys, and for them just to kind of throw you a bone, I don't know if they're just patting themselves on the back or what, but that's what they call it. It's not what I'm calling it, because there's nothing in here that isn't burdensome. But there is, for small practices, you will continue to receive 3 points for anything that doesn't meet the data completeness. The floor for quality measures was 3 for this past year. The floor is now 1, except for if you're a small practice. The floor is still 3 for you on those quality measures. Topped-out measures will become a factor this year. A topped-out measure is one where there is not a discernible difference between the highest and lowest performers on a particular quality measure. There's a lot of measures that are either topped out or getting very close to being topped out. So CMS is putting a cap on those. So instead of a max of 10 points on a topped out measure, the most you can earn is 7 points on those ones. And really, to even get the 7 points, you've got to be near perfect, because again, there's almost no difference between the worst performer and the best performer on that. So there are 6 measures that have been topped out for this year. And some of them, I think, will relate back to this group with oncology. So just be aware, if you were reporting on any of these quality measures in 2017, you're planning to do it again in 2018, the most you can get on one of those quality measures is 7 points now. We will see this list expand over time. I know there's a lot more than these 6 that are topped out or on the verge of being topped out. So we will see this topped out list expand each year going forward. Questions on that? Cost category, they threw us for a loop on this one. We weren't expecting to use cost again this year. So it was weighted at 0 last year. They proposed to weight it at 0 again this year, and then when the final rule came out, we were very surprised to see that they reversed their decision on that, and they are going to use cost at 10%. The reason why they reversed their decision on that is the macro legislation forces them to weight cost at 30% in 2019. That's built right into the law, so it has to be worth 30% in 2019. And they didn't want to have it go from 0 all the way to 30% in 1 year. So they're kind of trying to ease you into being assessed under cost by making it worth 10% this year.
I understand that cost performance weight is finalized at 10%.
So it's 10% of your MIPS final score. So throughout the MIPS program, you are trying to build that MIPS final score. Each of these 4 categories makes up a chunk, a piece of the pie that goes into that MIPS final score. So 10% of that MIPS final score is going to come from the cost category this year.
They'll measure you to the average cost for this diagnosis in your specialty?
Yes, in your specialty, in your region. Honestly, I'm waiting to see how this shakes out. They are literally flying the plane as they build it with this one. They don't even have their cost measures fully developed. Some of what they thought they were going to use, they at the last second decided not to. It's because they're literally building the plane while they try to fly it at the same time. So I'm a little bit worried on this. I really don't think they are ready to start measuring you guys on cost, but they're going to do it anyway, which frightens me and probably frightens you guys too.
Yeah, because nobody understands.
Nobody understands this category. CMS doesn't even understand this category.
You know, I could look at disease like colon cancer. I could look at the disease survivorship in colon cancer. I could look at disease of active treatment in colon cancer. I could look at it in terms of colon cancer and
Yeah, there's a...
How do you
there's so many unknowns with this cost category. So I'm still learning about it. CMS is still learning on it.
We're just going to take the diagnosis code, the EMR code, and then just get an arbitrary number.
Yeah, they know how much each one of these patients should be costing the system, and if your patient is costing the system more than the average, then you get docked.
How would you know that?
It's all off administrative claims, so there's no reporting that's involved with this. So that's the one good thing, I guess, is that while they are going to use this category this year, there's nothing additional that you have to do. There's no additional reporting involved. You're already doing this reporting on your claims, so this is all assessed behind the scenes, which scares me even more because CMS is on their own trying to assess you on this particular category.
This is very dangerous. For example, colon cancer stage 1, completely different than cancer stage 4, and you could use the same code to
Yeah, it's things like that. I don't know that there's only a handful of cost measures that they're even using, which again confuses me because there's so many specialties. Like how they could even come up with a cost measure that could apply across the whole healthcare community is beyond me. So yeah, there's a lot of unknowns.
It's obviously they can tell us, they can't penalize us.
Yeah.
Really, that's what it boils down to, because we'll just get tied up.
Right. Yeah, because as soon as they start to penalize you, yeah, so someone will sue them probably. That's what's going to happen. So a lot of unknowns with this. You are going to get some feedback, hopefully. So even though we didn't get assessed on cost for 2017, they measured you on it anyway, and they're going to provide feedback reports. Hopefully, we're going to see those sometime early this year. But everyone's going to get a 12 months of data for 2017 to show you how you would have been scored or how you would have been assessed had they used it in your MIPS final score. So hopefully that'll either exacerbate your fears for 2018 or allay your fears. We'll find out. Anything else here? So yeah, it's from the basics anyway. The cost category is two measures. It's the Medicare spending per beneficiary measure, and then the total per capita cost measure are included. So it's two sides that go into measuring your cost. I don't think there's anything else. Yeah, you're actually being assessed. Thankfully, they're not going to compare you to last year for this year's cost. You're being assessed within that period. So you don't get docked because obviously things change from year to year. Improvement scores. So in two of the categories this year, this is new. They're going to start rewarding you for improvements in the categories. So in the quality category, if you improve on one of your quality measures from one year to the next, you will earn some bonus points there. Same thing for cost. Even though you didn't get scored on cost, you did get assessed on cost behind the scenes last year. So if this year's cost score ends up being better than the previous year, then you can earn some bonus points there. So they'll start to reward you for improvements in this program. In the improvement activities, we don't see a lot of changes. They added some additional improvement here. We had 94 to choose from in 2017. We've got 112 to choose from in 2018. It's worth 15% of your MIPS final score, just like it was before. The weights are the same. There's these, each of those 112 is either a medium weight or a high weight. It's going to earn you either 10 or 20 points. It's still a simple yes. It's the honor system here when you're attesting to having these implemented. You're just saying that it's the honor system. You're telling CMS that you had a particular activity implemented for a minimum of 90 days during the calendar year. If you lie and get audited, that's when you'll get into trouble, so don't do that. Anything that you're attesting to, if it's the improvement activities, your quality data, your ACI, anything that you're telling CMS, make sure you have proof of it, because they can audit you up to 6 years down the road. And we see a lot of issues where something probably did take place and it probably was a legitimate attestation, but 4 years down the road when the practice manager changed hands and threw all their binders in the garbage can on the way out the door, they threw away that audit file. So when you get audited, you can't prove to CMS that what you told them was true, and so don't be in that boat. Save everything, scan it, back it up, make sure that you can pass an audit if you get hit with it. So for the ACI, for the meaningful use portion, you're going to have a meaningful use dashboard, and that's where you're getting that data from. Make sure you save that report because you're going to have to prove to CMS that you didn't just make up those numbers. Same thing with your quality data. Make sure that whatever reports you're printing out of your EHR, make sure you have those, lock them down, so that we coach our clients to create something called an audit file after every attestation, where it's a binder. It ends up sometimes being yay thick, that has every single thing CMS could possibly want to prove that what you told them when you attested is true. So the improvement activities is a big thing. Because there's not a report, it's the honor system. You're just telling CMS that you had a particular activity, and so you need to make sure that you have proof of that activity, so that 5 years down the road you can say, yeah, I was offering 24/7 access to my patients for this 90 days back in 2017. So it's different depending on which activity you choose, but make sure that you have proof of whatever you're telling CMS.
So individual improvement, like CME, requalification, does that go into the scoring, or?
CME stuff does not. Nope, has no bearing at all. No,
But
unfortunately.
if I make my employees go through mandatory CME, then that would be?
I don't have all the 112 activities. If there is one that speaks to CME, I don't think there is. I don't think there is one on there.
Talking about, obviously the more knowledge you have, the more, that's why we go to these meetings.
Yeah. Sometimes some of that stuff plays into these improvement activities, but you have to look through the laundry list of them and see what applies. But I don't think there's a CME one that ties back to the CME. There should be. It makes sense that there would be. But
Doesn't have to be logical.
that's true. It's the CMS, right? So additional scores. Yes.
Quick question.
Yeah.
It's back to quality, for example. Some of the oncology measures are very specific. So you can score, like you can have good numbers if it's an inverse measure or something like that, but you don't have at least 20. So then do you take a hit for that? Like
The case minimum. Yeah.
Right.
So there is a case minimum still.
Because there's some that are very specific. We might not, like a small practice, we don't even have any. And then some, I'm like, okay, yep, there's a KRAS here, and it was wild types, and we didn't give them, this EGFR.
Yeah.
So we did the right thing, but we were 100% not giving it. But
Right.
Yet we only had 4 people.
Yeah. So there's a floor to that. So the most you can earn is 3 points on those.
Right.
So he's talking about the case minimum. So we talked about the data completeness threshold for those quality measures. There's also a case minimum threshold. So you have to have a denominator of at least 20 in order to be able to earn points in that measure. So if you only have a denominator of 1, you only had 1 patient that measure applied to, and you attest to that, even if it was perfect quality on that 1 patient, the most points you can earn is 3 points on that measure. So when you're choosing your quality measures, it's to your advantage to choose quality measures that have a denominator of more than 20.
That's the problem. Some of them aren't.
Some of them you can't.
Yeah,
Yeah,
17 or
especially because they're
There's 3
they're very specific.
prostates that had to have radical prostatectomy.
Yeah, and so if you have other measures to report on instead, then choose those. But in some instances, you're stuck with having to report on ones where you don't have enough in the case minimum. In which case you're going to get capped at the 3 points then, no matter if you had perfect quality or not.
Which I think is a problem.
Yeah, but statistically, it's difficult to assess quality if you only had 1 patient, though. I mean, just like you have to have that minimum sample size to call anything significant. So that's kind of what they're getting at.
What quality measures are available. So
Yeah.
sometimes with a small practice, you're not going to. I mean, I've got 7 or 8 of the 6 or 17 that I can choose. I know we're well above the 3-point minimum, but
Yeah.
in that case, it's like.
So yeah, that is one place where you're done a disservice in the program. You could be a great doctor providing great quality to these 10 patients, but you're going to get docked in this program by reporting on that quality measure.
So the most, if you have 4 categories in 20 patients, the maximum award is 7 points. Is that correct?
Say that again?
I have 4 categories I'm reporting. If I have 20 patients per category, the maximum.
Well, no, the minimum case though, the minimum case only comes in under quality. That's the only place. It's only for the 6 quality measures that you're reporting on. That's the only place where there's this case minimum.
So I can know a maximum of 49 points.
So under
Times 7 is 49.
well, no, the max is 3 points. 18 is the most you're going to get. If you're under that case minimum across all 6 of your quality measures,
Correct.
the most you can get is 18 points. When your colleague, practice down the street could earn 60 as opposed to year 18.
Right, so the big practices have an inherent advantage of that.
Huge.
Yes.
Unreal.
Yes, they do.
From honors,
So there is.
From honors could usually get maximum points, he could only get minimum points. And then when we cut to be rated, he gets penalized.
So they did build in. They're throwing the small practice as a bone. It's coming up on a future slider. There is a bone they're throwing you by if you're a small practice, 15 or fewer clinicians, they're going to just automatically add 5 points to your MIPS final score. So that's one way that they're.
You're cutting 7 out of each. Measure, so.
Exactly. Right.
42 points down, but you're getting 5.
But you're going to get 5. So this is CMS's way of throwing you a bone, saying here. We're going to compensate you. We recognize that the small practices are at a disadvantage, but what they're giving you for that handicap does not overcome what that deficit is. Yeah, kind of, unfortunately. Let's see. Yeah, there's nothing more I need to say in that. Advancing care information, there's that ridiculous burden reduction aim again. They're allowing you to use whatever version of your EHR that you have. We were mandated that everyone had to be in their 2015 technology, which in and of itself was a joke. Just like with the 2014 version of your EHR, the 2015 version is slow to come by. So you can still use your either version of your EHR. If you are on your 2015 version now, though, for this year, and you're only using that in 2018, you're going to get a 10% bonus in this category. They did finalize some exclusions for 2 of the measures. So the e-prescribing measure and the health information exchange measure have exclusions. Those exclusions, when they finalized it, was retroactive to the 2017 program year as well. So if you prescribe if you write fewer than 100 scripts in your reporting period, you can just claim the exclusion on that one. If you transition fewer than 100 patients out of your care into another provider of care, you can claim the exclusion on that. They, for some reason, initially didn't pull those exclusions forward from the meaningful use program, and it meant providers weren't going to be able to attest to meaningful use or to the ACI measure, so they built those exclusions back in. There's no change to the base score. For the performance score, they fixed a problem from 2017 with the public health reporting part of this performance category. The 2017 version of this program did non-immunizing providers a disservice because the MICR measure, the immunization measure, was one of the performance measures, and so the only way to earn those 10 points was if you immunize. And so we said, well, what about all the providers that don't immunize? Now they can't earn those 10 points. So they recognized their fault there. They changed the program, so they've made that performance measure very vanilla now. It doesn't matter which public health registry you connect with. It can be MICR, it can be the cancer registry, MITRE. There's several of them. Birth defects registry. There's several that are in there. So whatever registry you are actively engaged with will earn you those points under the performance, and then anything above that, if you're connected to a second registry, you'll earn an additional 5 points or a 5% bonus score on that one. They did also keep the link between the improvement activities and the ACI category. There's 17 of the improvement activities that the way you would implement them is with your technology. So if you attest to one of those 17, it earns you some additional bonus points under ACI as well. So throughout the whole thing, you're trying to earn the best MIPS final score you can. It's anywhere from 0 to 100 points. There's a minimum threshold that you have to achieve to avoid that penalty. That threshold is going to change every year as expected. In 2017, it was a whopping 3 points, so anything above 3 points got you away from that penalty. This year, in 2018, it is 15 points. After this year, it is going to become the mean or median of the prior year's performance. So in 2019, we're going to see that number skyrocket, because it's going to be the average of all of this year's performers. So CMS set the rate for the first 2 years, but in the legislation now, in 2019, it's going to become the mean or median of the prior year's performance. So I suspect we're going to see that threshold shoot up to like 50 or 60 points next year. But for 2018, it is 15 points. The payment adjustment also changes, and so what's tied to the performance year, for last year it was plus or minus 4%, this year it's plus or minus 5%, eventually it's going to be plus or minus 9% as we get deeper into the program. So how can you achieve those 15 points? There's a few different ways that you can do it. If you're kind of looking for the easy way out, you just want to do that bare minimum to avoid that penalty, but you don't want to go through all the pain and suffering to try and score well, because it's just, there's no return on investment for it, perhaps. So you can still kind of take an easy way out and do some bare minimum that's going to avoid that penalty for you. You could report all the required improvement activities. So if you fully participate in that one category, that's really, to me, probably the easiest way out of the program to pull the chute and not worry about it. Look at that list of 112 improvement activities and find 2 or 3 that you already have implemented. The program doesn't require that you implement anything new. If you can find activities in that list of 112 that you already have implemented, and I guarantee every one of you can do that, you're just attesting to that activity being in place for a minimum of 90 days this calendar year. So if you can find enough of those activities that you already have implemented, just attest to that, and you're going to earn enough points to get over that threshold in 2015. That's all you'd have to do, and then you could, go provide good quality care and not get assessed on it. You could meet the ACI base score and then submit one quality measure that met your data completeness. That would also earn you more than 15 points. You could meet the ACI base score and submit one improvement activity, would also give you enough points. Or you could fully participate in just the quality category, because with that floor of 3 points, 6 times the 3, you're automatically going to, no matter if it's terrible quality or not, you're going to earn enough points to get over that 15-point minimum. There's a new complex patient bonus that's been built in. So if you have enough patients that score high enough on the HCC risk, they're going to add an additional 5 points to your MIPS final score for treating complex patients. But you do have to fully participate in any one category in order to earn those 5 points. You just don't get 5 points without any other reporting. And then there's that small practice bonus that we talked about. So if you have 15 or fewer billing clinicians against your 10, you are considered a small practice, and CMS is automatically going to add 5 points to that MIPS final score. All right, there's really not a lot of changes in the advanced APM arm of this. One thing they did change was in the APM scoring standard. I know folks didn't know there was those category weights were different for folks that were in the MIPS track versus folks that were in the APM track but still had to participate in MIPS. So they have changed that and kind of consolidated that into a single. They had it confusing where like MSSP ACOs had a different weights than some of the other APMs, the other types of APMs that are out there. So it just made it confusing and just a complete mess. So they've consolidated that. So there's just one APM scoring standard now. So if you are in an APM, if you're in an ACO but still have to participate in MIPS, this is the way. These are the weights that will happen. So it's 50% for the quality category. You're being assessed on cost under the ACO, so they don't assess you a second time on cost. There's already that shared savings part that's built in, so that's at 0. And then improvement activities is worth 20%, and the ACI is worth 30%. So I mentioned that, and then the other thing they added is a 4th snapshot date. If you're in an ACO, for CMS to recognize that you were in that ACO, you needed to appear on the ACO's participation list in 2017 by August 31st. They were doing 3 snapshots throughout the year on March 31st, June 30th, and then August 31st. So if you joined an ACO in September after that 3rd snapshot date, you didn't get the benefit of being in that ACO. CMS would not recognize you as an ACO participant. So they have changed that now for this year. There is a 4th snapshot date where they're at the end of the year. So as long as so any time throughout the year, if you join an ACO, CMS will recognize that and consider you that kind of provider as opposed to a MIPS provider. There's free help for everybody. Anyone who wants help in the MIPS program, it is there for you at 0 cost. There's a few different organizations that, depending on the size of your organization or the way that you work with some of them, that they can help you. If you're part of the Great Lakes Practice Transformation Network, they can assist you in this program. That's what this first box for our state would be. The small and solo practices, there was a flyer that you might have picked up for the QPP Resource Center. That's our web-based support that is CMS funded. That is available for free to practices of 15 or fewer clinicians. So any of those small practices can work with us for free. Through that, I highly recommend you sign up for the QPP Resource Center. It is free help. We are here for you. This is a full-time job to try and figure out. You guys already have full-time jobs. So let us do all the hard work for you. If you have a question, don't go searching the CMS website for that answer. You're going to spend all day trying to page through final rules. Just ask us the question. We can give you the answer, can give you the resource, can give you, you don't have to do all this work on your own. Through the QPP Resource Center, you also get project plans. We're going to ask you some key questions to understand how the program applies to you, and then we're going to feed you a project plan that's very specific to your practice. So that you're not doing things that you didn't have to do to fully participate. So I urge you, there's no reason why you should be doing any of this MIPS stuff on your own. CMS is funding these other organizations like us. MPRO is the one in our state that helps large practices. So if you have more than 15 clinicians, we can't help you through the QPP Resource Center, but MPRO is waiting to help you. CMS is paying them to help you with that. So don't do this on your own if you don't want to.